Yeah, I've been a CRNA for about a year and a half. I work at Kaiser West LA. Graduated from this school about almost 2 years ago in August of 2017. Sat somewhere over there. And so this is a talk on obstetric anesthesia. Here are our goals. We're going to talk about the physiologic changes and the relevant systems to the parturient, someone bearing a child. And that's going to seem a little heavy, but it's going to kind of come together at the end. And it's going to make it a lot more clear as to why we do the things we do. Obstetric airways is going to be pretty heavy as well, and it's going to do a lot. It's going to have to do a lot with progesterone and a lot of swelling in the airway, difficult airways, as you guys can imagine. We'll talk about hemorrhage, the hemorrhage kit, and some rapid infusers, which is definitely your specialty and not mine. And we'll talk about neuraxial anesthesia anatomy. And I actually took OB positioning and nerve injuries out. I didn't think we'd have time for that, but we'll cover the meat of it earlier on. So. All right, so neurologic changes. Because of progesterone flushing the system, you have a lower MAC, minimum alveolar concentration, which is basically like the dosage of a gas. And so you can see it's cut down by about a third. This has some implications because the pregnant patient, the nervous system is a lot more sensitive to local anesthetics, to gases, so they don't need as much. And you'll see in the pulmonary system, they also breathe faster, and so they'll fall asleep faster as well. If you look at the bottom photo there, this is a side view basically of the spinal canal, and those are epidural venous plexuses or Batson's plexuses. And so because of the pressure of the baby in the abdomen and also because of a fluid overload situation, those plexuses engorge, and there's a lot less space in the spinal canal. And we'll see why that's important later on, but just kind of keep it in the back of your mind. Cardiovascular, also because of progesterone, there is an increased heart rate and stroke volume, the product of which is increased cardiac output. So the point of this is that their heart's working overtime. And if it's working overtime, it's consuming oxygen, a lot more oxygen, a lot faster. And so in a situation where they're getting oxygen or say not breathing, they're going to desaturate a lot faster as well. And so also something to keep in the back of your mind. They do have increased red blood cell mass. So there's functionally more red cells, but if you look below that, their circulatory volume is also increased. You saw here that the venous plexuses are engorged. So that is because of pressure, but also because the progesterone causes them to keep more fluid on board. And so they have about 50% more blood volume. And what that does, and this is important because it dilutes all of the other factors in the blood. So if you have a platelet count of, say, 100, it might be cut down to 80 or 70,000. So they have increased bleeding risk. And this is why hemorrhage is such a big deal in the obstetric population. So cardiovascular, more so. If you look on the left photo here, that's the pregnant mother in the supine position. And because of the mass and the weight of the baby, the two vessels between the spinal column there and the baby are the aorta and the inferior vena cava. That's compressed. And so the venous return coming back to the heart from the lower body, from the lower extremities, is reduced. So this explains a lot of the leg pressure that mothers will feel, the varicosities, the spider veins, because that blood's getting pushed back down instead of returning to the heart. And if the heart's not getting blood back to the body, how can it give it, return? If the blood is not returning to the heart, how can it push it back to the rest of the body? So you'll see if they're in the supine position, they can tend to have some lightheadedness, some dizziness, some nausea, all products of low blood pressure because of decreased venous return. And so we like to place them in the left uterine displacement position, LUD. So in the photo on the right, the mother is now displaced to the left, the baby's off of those major vessels, and the blood can return a lot faster and more efficiently to the heart. And so if we're in a pinch, like let's say we just did a spinal anesthetic, the first thing we want to do is lay her back. And that is because the spinal anesthetics work by gravity. I'll show you a photo of that later on. In a pinch, in the case of low blood pressure, yes, we'll be giving them fluid, we'll be managing them with pressors, but in a quick pinch, something that can very easily and quickly be done, any quick intervention here is placing them in that left uterine displacement position. And here's some things that I've seen some very creative people place. There's a wedge, which is typical. You can place a pillow there, a bolster, a rolled towel, or a liter bag of fluid that they wrap in like a draw sheet or something. Anything to get the weight of the baby off of the abdomen. So pulmonary changes. This is all of our specialty here. Because of the fluid overload, and also the decreased venous return, there's mucosal capillary engorgement or airway swelling. So all of the blood passing through the upper airway has a harder time returning to the heart, yes, but also because we have more fluid on board and the mother's typically in active labor and pushing, the Valsalva or vagal maneuver of keeps that pressure in the head, neck, and trunk area. So if you could see, there'd be neck vein engorgement here in my external jugulars. The same thing happens for the pregnant mother, but all throughout the airway. And so this causes a lot of swelling. So on a DL, what we would normally see might be different because of all this extra tissue and edema. This leads to possible difficult airways. And so something that we classically have in the L and D ORs is airway adjuncts, which we may have in the main OR too, but especially here. Can anyone name a couple of airway adjuncts just right off the bat? Something that makes intubation or airway management a little bit easier. Glide scope, yeah. A different size laryngoscope. Different size blades. What else? There you go, small ET tubes. You have LMAs, exactly, there you go. LMAs. Some other things I can think of are like a bougie. The rigid ones, things that can, so that we can feel the tracheal cartilages in the event of like a grade 2 view. Flexible fiber optic, which we may not have in the room, but we want to know that we at least have available, that it's charged, make sure the glide scopes are charged. CMAX, McGraths, all of these things, great choices. It all depends on what the facility typically has. All right, so we need small ET tubes, like you mentioned, thank you. And that is because the airway is going to be swollen and a lot more narrow. But also after intubation, if we intubate, there's going to be even more swelling from the trauma. So we want to make it so that there is a minimal trauma as possible. We can accomplish that with a smaller ET tube. We avoid nasal intubations, and the reason is because there's a lot of mucosal swelling in the nasal passages as well, and that can lead to a lot of bleeding. We already know that the pregnant population is capable of a lot of bleeding, and so we do our best to avoid that area. Of course, the ASA, a difficult airway algorithm, may suggest you need to do that. There are other options, but keep it in the back of your mind that that's truly a last resort. Okay, so at the bottom here it says airway swelling is worse after laboring. A third of the population will increase their Mallampati score for about 1 point, and 5% will go up by 2. So here are the Mallampati scores here, 1, 2, 3, and 4. So a third of these people will jump from a 1 to a 3, or a 2 to a 4, and 5% of them will jump from a 1 to a 2 or a 3 to a 4. So like I said, a lot of the pushing causes more swelling in the airway, and that can cause a change in the Mallampati score. And what we may think would be an easier airway in the beginning of labor, by the time they get to about 8, 9, or 10 centimeters of dilation, that could change. So the point is, as she progresses, the chances of a difficult airway also progress. All right, so progesterone, you breathe faster, and they fall asleep faster with the gas. We mentioned that earlier. Also because of the presence of the baby here, this is basically a top view of the lungs, very, very simply drawn. And the pressure of the baby is pushing up on the lungs. And so if you think of the lungs as a gas tank, but instead of gas, you've got oxygen, you've got essentially less space in the tank. So you've got less oxygen in the lungs. So we call this our functional residual capacity, or basically the resting volume in the lungs. If we put her to sleep, she won't be breathing, and her only source of oxygen is going to be that which the oxygen is already present inside the lungs. And so the baby's going to be pushing down on that and decreasing the amount of oxygen we have available, and therefore the amount of time we have to desaturation. If you lay a pregnant mother flat who is apneic, you've got significantly less time, maybe about half that time you normally have before you start hearing the oxygen saturation monitor beeping in a lot lower tone. So the best thing we can do is pre-oxygenate. Does anyone know how long we should pre-oxygenate someone? Anyone, not just a pregnant mother, before an induction? 5 minutes is the classical time. That's nice. I jumped right on that. I didn't know that, and we definitely don't use 5 minutes, but that is what the textbook answers are. And the reason for that is because the lungs are full of a lot of other gases. Typically, like nitrogen is a pretty common one, and that's why we call it denitrogenation. We want to wash out that nitrogen and have it be 100% oxygen, or pretty darn close to it. On the anesthesia gas machines, what you can also look for is an end tidal oxygen, or the oxygen that we're exhaling, to be greater than 90%. So if, when we're sitting there, we're having them pre-oxygenate, we've got the straps on, and they're just sitting there wondering what's going on. We've already done timeout. What we're looking for, and now you can look for also, is that end tidal oxygen being greater than 90%. That shows that the oxygen she's blowing out is sufficiently high, which implies that the oxygen in her lungs in her resting state before she falls off to sleep and stops breathing is also sufficiently high. So 4 deep breaths in 30 seconds if this is an emergency. So even in a crash C-section, we'll put the oxygen on and we'll tell her to take huge breaths, as big as she can, 4 times. Very specific because we don't want her to do 7 or 10, just we want to get her quick oxygenation in the lungs and get her off to sleep in the case of, say, a crash C-section. And this is in lieu of the 5 minutes of normal breathing with the oxygen mask, which we typically may not have time for. So another big thing is a mask seal. We are giving 100% oxygen, and the room air here is about 21%. If even a few milliliters of that air gets into the mask, that's going to cause some serious dilution of the oxygen that we're giving her because it's such a low amount. 20% averaging with 100 can very seriously change the amount of oxygen she's getting. So the mask seal is very important. And so we can use straps. We can inflate the mask. You can pinch it off on the sides. If they have a high nose bridge, you can use the king mask, which is a little bit wider and a little bit more circular instead of oval-like. You can ruffle the facial skin. A lot of older patients have what's called facial atrophy, which is a lot of thinning in the face, a lot of loss of muscle in the face. And those things can make it like you're trying to, pre-oxygenate like a skull or something. So there's too rigid. And so the skin can kind of help pinch that off and make a good seal. It really makes a lot of the difference. Lastly, of course, you can use 2 hands. So, any questions so far? Try and slow down. GI and aspiration. So this is a huge thing here. So with the pregnant population, because like I said, the flooding of progesterone, it is often the culprit of a lot of the physiologic changes. The lower esophageal sphincter, which is the segment of muscle just before you get to the stomach, past the esophagus, is weakened. And so we give them all sorts of medications in pre-op. We can give them Reglan. We can give them proton pump inhibitors. We can give them H2 antagonists, basically things that decrease the acidity in the stomach, decrease the volume, or try and make it empty faster. And the reason is because the contents in the stomach should stay in the stomach. They're really harmful for the lungs for a couple of reasons. It's very acidic. The pH of the stomach is about 1 to 2, which is basically the pH of hydrochloric acid. And that can cause very serious chemical damage to the lungs if it were to arrive there. But also there may be food particles in the stomach, especially in the pregnant population. We don't want them eating, but let's say they came in, they didn't realize they're going to go into labor, they maybe have a sandwich 4 hours ago. There can still be some remnants in there, and those things can be obstructive in the lungs. They can cause aspiration pneumonia and death. The risk of death with aspiration pneumonia is actually pretty high, 30 to 50%. So if you were to aspirate, it's almost like a coin toss if you're going to survive. So those are terrible odds. And we don't want to risk that. And so we're very careful with NPO guidelines and with airway management. So we'll talk about something very common. We do it all the time, and that's RSI.
Is that just for planned C-section where you you're going to intubate somebody, or is that for all of the pregnancies?
Good question. So at the end, we'll talk about neuraxial, but a planned C-section, we almost always do a spinal for. And this is a big reason why, because we don't want to have to instrument the airway. However, the spinal anesthetic should not be used to replace the general anesthetic. It should just be used instead of. I know it sounds kind of crazy, but the point is we always still plan for a general anesthetic in the event of emergency. Let's say we can't get the spinal. No one can get the spinal. It's totally impossible. They may have had hardware placed in their spines in the past, like a fusion, say. All these things kind of make it impossible to place a spinal or even an epidural. So we may have to go to sleep. And so those patients going for a planned C-section should still follow the NPO guidelines of greater than 8 hours for any solid food.
Say somebody who's like just a natural childbirth plan. I mean, there's complications from that too.
Sure.
Because I remember when my wife we checked in and she was gonna be induced.
Okay.
We still ate like a full meal at breakfast time.
Right.
So.
It does make it tricky, and there isn't always a way to circumnavigate that. Some things we can do is, so let's say barring a crash C-section. Crash is a crash. No one can control that. We would wait. So like let's say you ate 2 p.m. and things are not progressing, we want to do a C-section, but it's only been 4 hours. If everything's going okay, and there isn't a risk for infection for the baby, there isn't an immediate concern of loss of blood supply, placental insufficiency, we'll wait 4 more hours and then do the C-section. That way it's just safer for her, right? Good question, really good question. All right. So we covered this, pre-op meds, RSI. So that would be the kind of the answer, right? We would do an RSI in the event of emergency. Theoretically, the RSI should make it so that aspiration doesn't happen, even in someone who, I mean, I could drop dead right now. I haven't eaten anything, but if I did, then I would totally aspirate that. So what we would do is an RSI, and we would just cross our fingers that none of that content's got in the lungs, and place that endotracheal tube as quickly as possible. So the rapid sequence intubation is supposed to minimize the amount of time you spend not breathing, right? So think of your typical induction. You lay them down, you put them to sleep, and you give them rock or VEC, and we need time for that to work. Or we want to put some gas on and get them a little more deeply asleep. We'll sit there for, you guys know how long that feels, like 1 or 2, 3 minutes, just waiting. And so that's time, we can't, first of all, ventilate those patients. That's the whole point of rapid sequence intubation. We want to prevent preferential insufflation of the stomach instead of the lungs. So this is a good point as well. In the event of a difficult mask ventilation, we'll use 2 hands and often ask you guys to squeeze the bag. It's very important you squeeze the bag softly and slowly. And the reason is because that lowers the pressure of the ventilation. So higher pressure doesn't go to the lungs, it goes to the stomach. The lungs can only accommodate a certain amount of air at a certain rate of insufflation. So all those things still somehow get air in the stomach if you're inflating too fast. Very regularly we'll be doing a laparoscopic case and I'll be asked to place an NG tube, even though I only maybe gave 5 or 6 puffs because I gave sucks or something. And there's air in the stomach already. So it's hard to avoid that. And so that's why the RSI is so instrumental here. So it does protect against aspiration, and it minimizes the amount of time we spend sitting there waiting so that they're not eating through that oxygen in the smaller set of lungs that we already know they have. So the first step is pre-oxygenation. If this is an emergency, we've got those 4 breaths. If not, and we've got time, have them breathe 100% oxygen. The medication sequence is fast. We use sucks because it's almost no time at all, less than 30 seconds. And then cricoid pressure is particularly important. And if you fail the intubation or we can't ventilate after failing intubation, we follow the ASA algorithm, which we're not going to get into. It's a lecture of that on its own. So cricoid pressure, very important, and it can be controversial. Some people say that if you put pressure on the cricoid, it simulates there being food in your throat, and then naturally everything starts moving. Your stomach can squeeze while your esophagus is trying to pass this food bolus into the stomach, and they'll aspirate anyway, or you'll just have a gag reflex. So it's controversial. However, it is still currently the standard of practice. There are research articles that suggest we don't do it, but as far as systematic reviews go, meaning a combination of all the literature, it is the standard of practice on a patient that is at risk for aspiration. So this is also called the Sellick maneuver, by the way. And so the goal of cricoid pressure is to push I meant to put a picture in here, push the larynx and the trachea back up against the esophagus. So on the side view, in the frontmost, you've got the airway, then you've got the esophagus behind it, and behind that you've got the spinal column. And so you push the trachea against the spinal column, and it squeezes the esophagus shut. And that's the whole idea, right? It's not to improve the airway view when we're doing our DL. It is to shut the esophagus. So this is kind of a difficult question, but what would be a reason why? I can think of 2 very easy reasons why we wouldn't do cricoid pressure no matter what. What is one that jumps out? Sorry, a reason why we would not do cricoid pressure. Yeah. Mm-hmm. Neck injury. Classic. Very good. Classic. We don't. You could make it paralyzed. You almost rather take your risks with aspiration. At least you got antibiotics. You got suction. A cervical injury. Classic reason we don't do it. The second one's a little bit harder. It's someone who's actively vomiting, because that can rupture the esophagus. If you're closing the esophagus out and the stomach squeezes while they're asleep and they can't protect their airway, the esophagus will be under high pressure because it's closed at both ends and it can rupture. And the only way to fix that is, through a thoracic surgery, actually. So we don't want to do that in those situations. So cricoid pressure. How much pressure should we apply to the cricoid cartilage? 6 pounds?
I was told that the pressure that you feel when you're pushing in a 60C syringe.
Oh, interesting.
So I was told by a doctor once.
Nice. I don't know. I mean, that sounds. I guess I have to feel that, but I'm kind of curious. I'm gonna try that like
Pushing-
on Monday.
You're pushing on a 60 cc and it's like really tight, small lumen, and it's not gonna go. So you want to do really hold pressure there.
Yeah. Okay. Interesting.
I don't know.
That's
Just an
cool.
example of
I'm gonna
it.
try that. Oh, sorry. Dang it. Numerically speaking, what do you think in terms of pounds, kilograms, anything? 5 pounds. It's pretty close. All right. I didn't know the answer to this. I had to look it up. We studied it, but you forget, and then you kind of just put as much pressure as you feel like you're not going to kill them. This much pressure, right? That's what it feels like, especially when they're not asleep yet. You don't want to put pressure when they're not asleep yet. They can throw up. You just want to find it, right? You just want to find it, and as they fall asleep, they're kind of sleepy. They typically won't remember anyway. That's when I start putting pressure if I'm doing it. So the answer is 3 to 4 kilograms or 6 to 9 pounds. So what does that feel like? I'm not even really sure. But physically speaking, if you took like a 6 to 9 pound weight and you put it in between your fingers and you try to hold it up that way, that's what you should feel when you're pushing down. So it's actually a lot. It's a good amount, which is obviously why we don't do it for neck injuries. So that is the classical answer. So I just want to mention that there were mixed answers from research. These were the numbers that popped up most frequently, and that's why it's a range. 6 to 9 pounds, 3 to 4 kilos. All right, so we maintain pressure, and we only release pressure after bilateral breath sounds have been confirmed. So, if I'm doing it, I'll hold the cardiac pressure for other CRNA or anesthesiologists, and they'll look at me and like, you can release now. I'm like, you haven't listened to the lungs yet. How do you know? Or if the cuff is not up, the whole point is to protect against aspiration, right? If you've intubated the esophagus, or if you've intubated the right main stem, then you're gonna have to adjust that. Or if the cuff's not up, all of these situations allow time for gastric contents to get into the lungs. That's exactly what we're trying to avoid. So sometimes I'll ask you to release pressure a little bit. It's usually in an emergency, or you've compressed it and we can't see anything anymore. We'll have you let up a little bit. There isn't like research that says you shouldn't do it, but if I promise you I can get it in really quickly and put the cuff up, you can let up a little bit. You can also abandon cricoid pressure only in an emergency. Saturations are 80%. They're gonna die via asphyxiation, not aspiration. So you can abandon that, and then we can start the ASA airway algorithm. We'll worry about aspiration pneumonia or pneumonitis later. So those are the only reasons why you would abandon it. Emergency or slight relief just before we intubate. So sometimes you'll see the anesthesia provider doing a DL, and then they'll go around themselves doing this. That is typically not cricoid pressure. It's called burp, or there's another name for it too, OELM. The point is, it's different. And I want you to know the difference. So we talked about cricoid pressure. Burp stands for backward, upward, rightward pressure. The difference is that you're not doing this to the cricoid. You're going a little bit higher to the Adam's apple, the laryngeal cartilage, the thyroid cartilage, and you're trying to make it so it's easier to intubate. This has nothing to do with preventing aspiration. So this is a guesstimation of where the glottic opening is. If I'm doing a deal and I can't see anything, I'll do this to orient myself. I'm looking at a bunch of pink, So this mobilizes structures. It gives you some reference, okay? So what is something, we're talking about difficult intubations, we're talking about aspiration. We want to minimize the amount of time that we spend mucking around in there. What is something we can classically do before to help intubate? Something just really easy. Position, right, exactly. Build a ramp. We can build a ramp. And what the ramp does is it aligns the axes of the airway. There's different directions here. Like if I open my mouth, you can see directly into the back of my throat, not my airway. If I were to tilt my head back and lift my head, you could see my trachea, but not my glottis, my glottic opening. So and I'll show you a picture. What this does is it aligns everything a little bit easier, especially in large obese patients or in patients with large breasts. These things are particularly helpful. This part of the blue line here denotes the axis of the tragus of the ear, which is right in the front here. And this is typically, imagining where her sternum is. It's probably more like over here, because the breasts are there. That is a classic situation of poor position. That's not the sniff position, right? If you ramp them, this is what you get. Alignment of the tragus of the ear with the level of sternum. This is a little bit high, but it's okay. And theoretically, this should align the airway a little bit better so that we have more direct access on direct laryngoscopy. And so these are the axes I'm talking about. OA stands for oral axis, LA's laryngeal axis, and PA's pharyngeal axis. In a normal patient going to sleep laying down flat like that, if you can breathe, it's all misaligned. They've all cross-sectioned. And here, they're a little bit closer. They're not exactly in the same line, but that's why we do laryngoscopy, to push all those tissues aside. So this is something we can do very easily, even before the patient gets in the room. Okay. Any questions on cricoid pressure, burp technique, or ramping? All right. Let's talk about hematologic changes. The 4 T's are of the causes of postpartum hemorrhage. The most common one is uterine atony, or no tone. So the uterus has a certain size and shape. It gets dilated and very thin once the baby's grown in there for 9 months. And after the baby's birthed, the uterus is still the same size. It needs to shrink back down to its normal size. And if it doesn't do this, it will bleed. I'll show you why. So this is the number 1 cause of bleeding, of postpartum hemorrhage, And just to remind you, they already have the dilutional coagulopathy, meaning because they have fluid overload diluting all of those proteins that normally help shut blood, shut open vessels. And so how do we manage uterine atony? This is on the top left here, what the uterus looks like after delivery if there is appropriate tone. So this is, you can tell she's had a child because it's very large, so the uterus is much smaller, about a third the size. And after delivery, if there's no tone, on the bottom right there, it's very thin, it's muscular, but it's not contracted, and it's bleeding very heavily. So you can notice how there can be a significant amount of blood pooling in the uterus before it's actually visible externally through the vagina. So if there's even a slight amount of vaginal bleeding, or it's not vaginal bleeding, it's just bleeding that you can see through there, it implies a very serious amount of bleeding still in utero. So this is the reason why uterine atony causes bleeding. There are these vessels here, they're called spiral arteries, and they attach to and feed the placenta and therefore the baby. And that's great, that's normal. After the delivery, these spiral arteries, they're spiral because once they contract, it basically closes on itself. It coils shut like a snake vice. And so if it's soft, those spiral arteries stay open. And this is why the drugs that we give are called uterotonics. They give the uterus tone. They make the uterus tight, and they shut those spiral arteries, and they decrease bleeding. So our role here is to understand these drugs very superficially, know how they're given, and have them prepared, and have them always be available in event of emergency. So uterotonics, there are 4 or 5 very common ones. These are the ones that we have at West LA, and they're pretty much everywhere. They're pretty ubiquitous, but every facility is going to be different. And so you want to know the contents of it, so you want to know it's complete. And you want to know that they're readily available, and they're typically also refrigerated because they're used so rarely. So this makes the drugs, we don't have to keep tossing them out. If they're colder, they last longer. So I've also listed them in the order that they're typically given, right? So maybe you want to have more of these available since we use it most often. We may not get down to these drugs if we can control the bleeding as we progress through their usage. The first one is called oxytocin or Pitocin, very commonly given. It's diluted and titrated with an IV. So they come in little vials. So you also want to accompany that with a 500 cc bag or a liter bag, because it's very rare that we'll push that because it causes a lot of hypotension. The next one is vasopressin. Have that available, but it's typically given via uterine injection by the OBGYNs. So we have to find a way to give it to them sterilely. Methylorgonavine or Methergin. These are all drugs that close the uterus and make it tight, right? Methergin is given intramuscularly typically, but it can be given IV. It increases the blood pressure as well significantly, and that's why we don't give it to patients with severe hypertension or intracranial bleed, say. If given IV, it causes that much more profound hypertension. Prostaglandin F2 alpha, or Hemabate, is only given intramuscularly. I'm not suggesting that it's your role to stop silly-headed CRNA or anesthesiologists from giving an IV, but it's something to keep in mind. It's all about awareness in the OR and being, one with the team. And if you see this happening, it wouldn't hurt to ask. I've heard that's only given IM. I would be very surprised too to see it given IV, and I would definitely ask. Is there a reason? that I don't know what you're doing that for? It's only given intramuscularly, and that's the reason. The reason is because it can cause a life-threatening bronchospasm. Prostaglandins in the body normally cause smooth muscle contraction. The uterus is a smooth muscle, and we're asking it to contract. The bronchus is lined with smooth muscle. This is what a bronchospasm is. So it can cause a life-threatening bronchospasm, especially in asthmatics, so we don't give it to them. And that's why it's 4th on the list. And lastly, and because this is kind of a last-ditch effort before we go into surgery to stop bleeding, is misoprostol or Cytotec. TR is transrectal. They're actually tablets. You open them up, they look like Tylenol, like those little peelbacks. And The typical dose is 800 milligrams or 4 micrograms or 4 200 microgram tablets. So the point here is have it available. It may not be used. So check expiration dates because they may be expired. They may not work very well. They need to be refrigerated, and you need to have a lot of them because one tablet's not going to cut it. That's not the dosage, right? So that's nothing to keep back in your mind. I'm not suggesting that we understand the dosages or how all these drugs exactly work, but we want to know that we have them in the right dosage, in the right availability, and they're refrigerated and available. Especially the Pitocin, to have it with a 500 cc bag, which we may typically have in the LDORs, but not in the laboring rooms. So if we give you a call and we're like, oh, can you please help us out? We need this, this, and that. We're going to the labor and delivery room. You might imagine that they typically don't have those things. So a lot of these things that I'm learning about our interaction is from our anesthesia technologists at West LA. They bring things to me that I didn't even realize I needed. So it's good to keep these things in the back of your mind and have it in context. So if we anticipate hemorrhage, say this is her fifth baby, her fifth C-section. Those are all things that increase the risk of hemorrhage. She may be very large. The baby may be very large. So these are all things that let us know this is going to be maybe a serious bleed. So you want to have the appropriate equipment. So large bore peripheral IV access. Have the kits ready. Make sure we have extra ones since we may miss, for example. A cordis and central line. Those are all kits that we can have all available. Blood tubing primed with NS, not LR. And the reason is because this may or may not be interesting to you, but LR has some calcium in it, very small amounts, and that calcium can promote clotting of the PRBCs we hang. So just keep in mind, it's always got to be NS, and now that's the reason why. That's the reason why. Plasma light, they have said in children can work, but if you're in a pinch and you're not sure, there's typically NS available. So fine with NS. And we have to use a fluid warmer. Blood is very cold. We keep it in a refrigerator in a blood bank. We'll talk about why cold patients promote more bleeding. And so we want to use the fluid warmer as much as possible so the patient can stay warm and have a better chance at clotting that blood off. Have pressors available. Some 250 cc bags to dilute it if we have to hang a drip or if we just want to have more access to 10 cc pushes. And crystalloids and colloids. Just want to note here that we don't use Hextend, secondary to platelet inhibition. So fun fact, Hextend or hetastarch is actually used in cardiac surgery to prevent the closure of those stents because they inhibit platelets. We already know our patients are prone to bleeding and they have low platelets because of the dilutional coagulopathy. So Hextend is one of the colloids that we don't want to hang. Maybe have it available for some reason, but it really shouldn't be given. You want typically crystalloids, colloids, blood products.
What about the cell saver?
So that's a great option. Great option, cell saver. I know a lot of cell saver it depends on the type of surgery. You can't use cell saver in a C-section, say. If she's bleeding, right. Do you remember why?
No, yes, you can. The AABB changed the guidelines.
Is that right?
Yeah, you can use it.
Did they introduce like new technology to filter it?
Local sound filters.
Nice. Okay, that's new. Thanks for telling me that. I appreciate it. So previously, you couldn't use cell savers, thank you, for C-sections. And the reason was because you would aspirate amniotic fluid as well. And those have proteins that can clot inside of your blood and cause like a PE and death. So that's really interesting. Leukocyte filters, I'm gonna look into that. So a cell saver, add that to the list. Thank you. Timing. After the blood is sent to the OR and leaves the blood bank refrigeration, you've got about 30 minutes, according to the Journal of Transfusion Medicine review. 30 minutes before it's no good. That's because it can be no longer considered sterile or clean. It can cause infection. There's always a risk of like hepatitis with blood transfusion, and so the viruses can be replicating in the blood if the temperature comes down above into like say room temperature. So we got 30 minutes to give it. If we're not going to give it in 30 minutes, it should be sent back to the blood bank, or we can have a cooler or put it in refrigeration. We only recently got a refrigerator in our LD and OR central cores. That's kind of crazy, but it's there now, but we didn't have one before. So we would either have this, and if we didn't have that, we'd have to go back and forth to blood banks. Very inefficient. So maybe you could ask, if you're not sure you're going to hang it, and we're not sure either, you can ask blood bank, do you have a way for us to refrigerate this if whatever institution you're at doesn't have these refrigerators. But just keep in mind, about 30 minutes. It's always helpful to remind the providers in the room, and it's been about 20 minutes now since I brought this blood over here. If we're not going to hang it, I really don't want to waste it. And that'd be a big shame. Blood is something we're always short on, So I thought I'd include it here just for reference. About 30 minutes to give it. Once it's hanging, you've got about 4 hours to give it because it's going to go into that patient for sure. But 30 minutes if it hasn't been hung yet. So cold and bleeding. There's a saying in trauma surgery, they're not dead until they're cold and dead. And the reason is because if you're cold, it causes so many metabolic derangements that if you're not alive, it's probably because of those derangements or you've exsanguinated, right? So keep the patient warm. So we can warm the room. We can use the hotline, that's classic. Forced air warming, or hot blankets, another thing. Forced air like a bear hugger. The cold body temperature leads to dysfunctional clotting. The proteins in our body function well because they're at our body temperature. The moment they start to fall below that temperature, they unravel. Proteins are folded in a special way and they unravel and they don't work anymore. They don't even know what they are. So they kind of just float through the body uselessly. Same thing with platelets, which is also protein. So this compounds the dilutional coagulopathy we already know they have because they have so much blood volume. And so the point is we really want to keep these patients as warm as possible, which is difficult because we've typically draped from the xiphoid or just up to the breast line down. So there's a lot of skin that's exposed. Throwing blankets on the legs or over the chest or around the head, all of these things can really help out. Rapid transfusers. Pressurized forced fluid entry. So this is a picture of the Belmont. That's because that's the one we have at Kaiser West LA. I know we have level 1s, all different kinds of transfusers. This is just one we have. It is self-priming, but priming is the key there. I don't know if the other ones are self-priming or not, but the tubing for the Belmont is huge. It's like 200 milliliters. So you can imagine if it didn't prime, if it malfunctioned, or if you see air in line, that's likely going to kill the patient. So, and I'll show you a picture as to why. So it's very important they get primed. Right? So for a faster transfusion, you can hook up the Belmonts directly to the access hub. So if you place a peripheral IV, you can flush it with a saline syringe, but don't hook up these pressurized caps to them because these blue things, they get pushed in, and their goal is so that it doesn't back bleed out of the vessel. So that once you disconnect your luer lock syringe, it stays flushed. So that back pressure is going to be applied to the Belmont as well, or your level 1. So it'd be wise to not hook this up directly to the IV before you hook up the Belmont male catheter. So this right here is what the central line looks like without those hubs, as I'm sure you've seen. And if you hook up directly to that, you can get significantly faster transfusion. That's a pigtail on a peripheral IV. We want to avoid those altogether because you can't detach those. They're already built in. So if that's all you've got, just hook it up directly to the peripheral IV. All right. So this is also a picture that I took from the Belmont little catalog there that shows like instruction manuals. And it shows you on the left side is the milliliters per minute flow rate. So it's like a liter bag. And on the bottom here, it shows based on the size of your access, how fast that fluid or blood can get in. So blue is crystalloid, classic fluids, and red is PRBCs, which you can also basically apply to albumin or even Hexten if it's not an OB case. As you can see, it's almost half, not quite half, especially the larger bore access you get, it gets to be pretty darn close. The Belmont won't transfuse past a certain point unless you let it. So if you set it's your typical cap to 300 millimeters of mercury, it will push that pressure blindly into anything. You disconnect it, it's going to flow out, right? And so the pressure is fixed. The rate of transfusion changes based on the size of access you have. And so it's important because if you're giving blood, you can destroy those blood products if you set the pressure too high. So let's say this is a real emergency and this patient's likely going to die and we're doing everything we can and we're going to change those guidelines, those guardrails to 400 millimeters of mercury. Serious hemorrhage. I'm doing something. I'm asking you, Nady, Alejandra, Ellison, can you please turn it up to 400 because we're not getting we're not getting fluid in fast enough. That may be fine. If you hang blood at that pressure, it's like you won't even be able to tell, but the blood cells on a microscopic level are getting lysed. They're exploding. They're completely useless after that. So it doesn't matter if we're getting the blood in if the blood's useless inside of their bodies. So that's why it's so important to know what pressure we're pushing at with the Belmont of level 1 and what product we're giving, right? So suggested flow, it's almost about half are crystalloids, and you can also damage the vessel. You can blow your only access. Let's say you got a 14 gauge suite, and then it explodes. It's useless after that. So all of these are reasons why we don't want to transfuse too at too high of a pressure. Also, you can damage the catheter and then hemolysis of the PRBCs, like we mentioned. So there's different types per facility. I'm sure you guys are all experts at what you guys use at your facilities. I'm not an expert even at the Belmont, and we use that all the time. So it's important to know different flow rates, the different pressures, and have the contact information for the manufacturer in case it's a problem. We probably won't deal with it during the emergency, but let's say there's an emergency soon to follow shortly after that in the same day. We need that Belmont to be working, right? So these are all things to keep in mind with our rapid transfusers. If you are at a different facility where there are no rapid transfusers, and that's not uncommon, you can use a pressure bag. You hook up the pressure bag to blood or fluid, and you want to inflate it manually to about less than or equal to 280 to 300. I say 280 because those things, they're not digital. They're just like, you're just trying to get it just right. So it's better to be safe. Better to be safe than sorry, especially if you're going to be destroying blood products. To have it at a little bit under 300. Mind you, there's no air inline detection on these pressure bags. So if you use a pressure bag for an A-line or something like for CVPs, PA catheters, it's not going to matter because there's no way you're just using it to flush. You're not going to get 500 cc's of fluid in there. But if you're giving it to give the blood product, it's very likely that down in this area where there's the little drip chamber, that if that's empty, and this is at 300 milliliters of mercury, you've probably already got some air to the patient. Best thing you can do is depressurize that bag or just clamp it, right? So air embolism is a big deal. So very important to prime rapid transfusers. It will stop if it detects air in line, but like I said, the pressure bags don't have sensors. So an air embolism, this is obviously animated, but that white circle there represents air. And I'm sure we've all been there trying to shake those IV tubing for a pediatric case. And if there's air in there, that's what we're trying to get out. But whenever there's air in there, it's hard to get the flow to continuously go. And it has to do with like adhesion of the water molecules. But the point is, air prevents fluid movement through a fixed chamber like an IV line. The same is true for the pulmonary vasculature. If there's air inside of the pulmonary vasculature, blood stops going back to the heart. Same thing with the pressure of the baby on the abdomen. If you're laying supine, the blood stops returning to the heart. The mother can end up hypotensive, and this is also going to contribute to that. So if you ever anticipate this, or someone says, I think this is what's going on, because you really can't tell. You just have hypotension. Maybe you go into asystole. The first thing you want to do is put the patient in Durant's position. It's very helpful to place this patient there as soon as possible. I tilted the photo because this is technically Durant's, but it wasn't Trendelenburg enough. But it really should be in Trendelenburg and left lateral decubitus. So getting a patient there, especially if she's, say, an obese mother, and I say that because we have a very large obese pregnant population, can be difficult. We may need 5 or 6 people to help us to get into the position. And it could be the difference between whether or not the mother survives. Those are Mayfield pins because that's not an uncommon thing to have an air embolism in a neurosurgical case. So that is the position. Trendelenburg, which is head down, and left lateral decubitus position, which I'm happy I've never had to do that before. All right, so neuraxial anesthesia. There is equally a high of a fatality risk of general anesthesia because of a cannot intubate, cannot ventilate scenario and aspiration, 50%, right? So if either of those things happen, fatality is a very, very serious risk there. So it's best to maintain spontaneous ventilation. So we talked about the C-section before, a planned C-section. We want them to be NPO, even though we don't anticipate doing general anesthesia. The best thing to do is have them be breathing on their own and be numb. Go through the surgery awake. And also you want to be awake for the delivery of the baby typically. So the best thing to do is neuraxial anesthesia, and that's accomplished with epidurals and spinals. So these are dermatomes. Dermatomes are areas of the skin that will be numb if you block that level of the spinal cord. So it says T1 all the way to T12, and then L1 all to L5, and so on. So our goal with the spinal is to make it numb all the way up to the level of T4. That's the nipple line, right? So it's not only sensation that we're blocking, we're also blocking motor activity. So the nerves that feed those areas, if they function for feel, or if they function to move a muscle, can't do that anymore, or they can't do it very well. It depends on the concentration of local anesthetic. But the point is, you have intercostal nerves in the ribs, right? Those function to help us move the ribs. The diaphragm's the primary thing there, and the diaphragm's protected because it's all the way up in the neck, the nerves that feed it. But the point is, the mother can't feel that she's breathing. even though she may be breathing totally fine. She'd be saturating 100%, but she'll get restless and become very tachypnic. And the reason is because they just can't sense that they're breathing. So it's good to remind them if you're there, you're actually doing great. You can see misting in the mask, in their face mask. You can see a good waveform with 100% sat. Good reminder, but it can also be bad. You can also have a high spinal, and we'll talk about that last. So I wanted to give you guys an understanding of what an epidural and spinal is, like visually speaking, so we know what's going on and what our goal is. So the epidural contains a lot of fat. It is outside of the dura mater, epidural, and then the subarachnoid space is below the arachnoid mater. That contains the cerebrospinal fluid and the spinal cord. If you get local anesthetic into the epidural space, it spreads a little bit, but it's a dry area and it's covered in fat, so it's minimal spread. The spinal anesthetics are basically flowing through you can consider it the neurologic plumbing. The cerebrospinal fluid is in fact a chamber fluid filled, and other fluids can move around in there if you place them there, like a local anesthetic spinal. So they work by gravity. Spinal anesthetic, local anesthetics are very heavy, and so if you place a spinal in me now, it'll drift down below and make maybe my knees weak. And so that's the reason why it's very important. After we place a spinal, we want to lay them down immediately so it drips to the areas that we want it to when they're laying flat via gravity. So the difference is the target location of the local anesthetic. So the epidural, the goal is to numb the nerves. The spinal anesthetic, because it goes deeper past the dura mater into the canal, numbs the spinal cord as well. And so you get a lot more dense of a block with the spinal. The nerves that come out of the spine also dictate the size of our vessels in our body. They make them contract or they make them dilate. When you block those nerves, they open up real big because the nerves that are controlling the tone of the vessels they're being blocked, they're no longer functioning. So hypotension is one of the very common risks after a spinal anesthetic. So if you have a hypotensive patient who's now very vasodilated, the vessels are enlarged, and you have bleeding, and you have a mother who's prone to bleeding, and they're cold. I mean, all of these things are kind of a recipe for disaster. And so our goal is to counteract all of these things. We're kind of giving ourselves more problems, but that accomplishes the goal of the anesthetic, right? So the location of the local anesthetics is the difference between a spinal and epidural. This photo shows the difference. Once you're injecting the local anesthesia, the target. So on the bottom one is the spinal, and the top one is the epidural. And you can see that they're in different chambers in the spinal cord. Here's epidural dosing. The takeaway is this. Very simply put, if you look at the bottom, it says fentanyl. On the left is epidural, on the right is spinal. The dosages are almost 1/4. It's not uncommon to push the epidural dose into a spinal anesthetic. It's very important to know if we're doing a procedure together, to know what procedure we're doing and what drugs. Let's say I'm sterile and I need someone can you open up that fentanyl I have there? Fentanyl is 50 mics per milliliter. There's typically 2 cc's in there, so 100 mics. If I take it all out and I'm prepared to push it into the spinal, it would not hurt, especially if it's 3 o'clock in the morning, to say, hey, is this an epidural or a spinal? I just want to know what procedure we're doing. And if you're pushing that dose into the spinal canal, the patient's likely to stop breathing. So it's good to know what we're doing, and if I'm assisting an anesthesiologist, say if they get called up for my help, I still want to know everything that's going on, whether or not I'm doing the procedure, because it's not about who's doing what, it's about the patient, right? So the dosages are about a fourth of that, and it's likely if I'm going to put that into the spinal canal, I'm going to also need your help to dilute it. So good to know what we're doing and the dosages of the drugs we're giving. Any questions?
On that last slide?
Yeah.
The inverse seems to be the case with the other local is on the spinal though, right? Like it looks like you're using.
Yeah, that's a good observation.
Why?
Because a spinal's goal is to be completely numb,
Oh, okay.
and an epidural's goal is to help with pain on say for labor. It's a good. That's I didn't even realize that. I mean, we do it thoughtlessly now, but you're right.
The volumes are so much smaller.
The volumes are smaller and they're really dense. So we use like 0.75% versus 0.2% for an epidural. So we want a really dense block because we're gonna do surgery for a spinal, and that's the difference there. You can do surgery for an epidural, and that's when you use those spinal dosages and high volumes as well.
One more question?
Yeah, of course.
How do you inject such a small volume for the epidural? Like, how do you draw those up? Do you dilute the drug to a smaller?
We
volume?
use larger syringes.
Or, but like you would just like use normal saline or sterile water.
A sterile, you can use it as long as it's sterile and preservative free. Oh, thanks for reminding. I meant to put that in the slides. So
Because it
you want
seems
it
like
to.
such a small volume. Like how do you even measure that?
It's tricky. Yeah, there's a lot of this. You know.
Is very small.
Yeah, right. It's the same with insulin, right? That's a good observation.
Exactly. Yeah.
Our goal is to rely is for the epidurals to rely on spread, right? This is a fixed space, and if you inject local anesthetic into the epidural space, especially when the epidural veins are already engorged, because I showed you the plexuses were full of blood, you get more spread. It goes to areas that we didn't anticipate, and that's what we're going to talk about with the high spinals. But just really quickly with the neuraxial equipment, we want to have the kits there. Lately, ever since that hurricane, the kits stopped coming with Marcaine inside of them, right? I know I'm sure everyone's like, oh, yeah, it's a real pain. I think some of the kits are coming back, but it's good to have a variety of options. Just bring them in. You can also look in the back to see if it's going to be available there. Sterile gloves of various sizes, local anesthetic drugs, plus induction drugs in case of emergency. I meant to take that out because I was going to ask you guys a question. CHG wands, and there are 3 more things that I want to know about. So if you're using local anesthetics in large volumes, what should always be readily available? Sorry? Lipids, nice, classic. What else? I already kind of gave away one. Induction drugs. What else? Airway equipment. So we need the lipids because of local anesthetic toxicities that I'm sure you're thinking. And if we're already knee deep in local anesthetic toxicity, we need lipids. We probably have to get them. We have to prime the tubing and give it, right? It's going to take some time to get that in. Then the lipids have to work. Once we get a good amount of it in, I probably don't have a rapid transfusion. I probably wouldn't rapidly transfuse lipids. But the point is, the patient's probably going to code first. Maybe they'll be hypotensive, right? Maybe they'll be hypotensive, they'll be bradycardic. These are all signs. Numbness or tingling in the lips, but they may code. That's kind of the end point there, and that's what we're trying to prevent. So we need induction drugs and airway equipment. Probably won't even need induction drugs if they're already coding. Yes?
In the airway equipment, do you guys have nasal cannulas and mask with the CO2 monitor? Because ACLS guidelines are changing and now they're suggesting to have everything in play. Because one of the first things my sense is the CO2 on the patient going through.
Nice. I like it. Way ahead. Our kits, and it's going to be different based on everyone else's institutions. Our carts have these kits that have all those what you're saying. Same thing with our code bags. West LA is a little bit more on the conservative side, so we like to have more things than less. And so if we open up the kit, it would all roll out, and you'd see oral airways, nasal airways. You'd see MAC 3, 4. Might even see a WISHIPL if you're doing a kid, because it's supposed to be prepared for even children, right? All of those things will be there. I don't know what your facilities will have in terms of preparation, but it'd be good to just grab a couple and bring them to a code or say. That does change a lot. I've been in some situations where I'm in a code, and the respiratory therapist, in the confusion and the drama, bagging like crazy. They're not doing the 30-2 according to ACLS, right? If they're not intubated yet, and they're also not ventilating. So the oral airway in those situations, great. So that's a really good point. So lipid emulsion is 20%, typically associated with epidurals, because as I mentioned, we give those in high volumes. If the epidural were to, say, get into the spinal canal, I don't even know that there would be salvaging that. But giving an epidural is typically when this is going to be necessary, because if I got a spinal dose into the vasculature, the concern is that it gets into the vasculature, right? We're supposed to put them around nerves, but if they get into the vessels, that's when toxicity happens. So this is to counteract intravenous administration of local anesthetics, which cause LAST. But it does not work in a high spinal. Because the high spinal, what is a high spinal, right? I showed you the picture of the epidural venous plexuses engorged and the spread of the local anesthesia as you inject it. The high spinal means that the local got to areas that we didn't intend. I also mentioned that the local anesthesia prevents nerves from normally functioning. If they get to areas that of the nerves that function to help us breathe, well, we can't breathe, right? The concern is always ventilatory integrity. There is no reversal for this. There is only airway management and waiting until the local anesthesia wears off. The problem is also that I told you that the nerves that control the vessels and their tone and their size, once they get blocked, they don't work and the vessels dilate, right? If you have system-wide dilation, that's shock. That's like the definition of distributive shock. all their vessels are open, there's essentially no blood pressure, right? So a code is also a very serious risk. It starts off with ventilatory integrity and difficulty breathing, desaturation, and ultimately they may code, not because of desaturation, but because of circulatory shock. So does anyone know what the earliest sign of a high spinal might be? Earliest. That's a tricky one. Sorry? It could be breathing. It could be. But before that happens, typically they get numbness in their pinkies. Fun fact, yeah. The pinkies are innervated by C8, which is why this is my last photo. C8 is cervical. Well, it's cervical. This doesn't really show it very well, I guess in the one on the right. But the pinkies are typically C8, C7. And so C3, 4, and 5 keep the diaphragm alive. If they're getting numb at C8, they're getting pretty darn close. So to the diaphragm, and the diaphragm's our major muscle for respiration. So the issues with high spinals, there's no drugs to give other than induction drugs. Put them to sleep, intubate them, and keep them asleep until the local anesthesia wears off. We'll test that on the anesthesia gas machine, how well they're breathing. But the point is, all those situations that we tried to avoid in the first place with neuraxial anesthesia could very well put us in a situation where we have to instrument a difficult airway. And that's why airway anatomy and understanding all of the adjuncts and all the obstacles you might encounter is so important, even if it's not the primary plan, because it very well can become the primary plan. Yes?
So when you're planning it, where are you actually trying? You're trying to go up to as far as
T4. T4 for a spinal, for a C-section. Yeah. And the reason is because there's a lot of pushing and pulling, and that can be very uncomfortable even as high up as T4, even though we know that the uterus is innervated by the lower thoracic nerves. So that pushing, and even in a great working spinal, once you're pushing and pulling, trying to get the baby out of the uterus on a C-section, they can be pretty uncomfortable. It's not uncommon to have to give fentanyl in those situations. Any questions? All right, thank you. That's all I have.